Hello, my name is Keenan Bulnamore. I'm a third year medical student at Western Michigan University School of Medicine. I'm presenting this poster titled Emotional Lability in an Atypical Acute Lymphoblastic Leukemia Patient with Methotrexate Induced Leukoencephalopathy. So some background information. Methotrexate, being a dihydrofolate reductase inhibitor, is typically used as a chemotherapeutic agent against ALL. Aggressive ALL has a propensity to spread to the central nervous system, and so intrathecal methotrexate is used as prophylaxis against this spread. Toxicity related to the intrathecal therapy accounts for 9 to 11% of patients and is consistent with stroke-like symptoms. So in this case, we'll describe an atypical case of B-cell predominant ALL in an adult who presents with a unique manifestation of emotional lability. Atypical symptoms, such as emotional lability, have been rarely documented, but are important to consider for clinicians identifying methotrexate-induced neurotoxicity. So our case is a 26-year-old woman with a history of B-cell ALL, diagnosed recently, presenting to the emergency department with sudden onset slurred speech. Her current medication regimen includes IV rituximab, oral mercaptopurine, prednisone, and intrathecal methotrexate. On the day of presentation, she received her 10th cycle of intrathecal methotrexate. While obtaining history from the patient and her mother, her episodic slurred speech worsened, and while it worsened, the patient began to shout, cry, become aggressive, detach her monitors, and was overall uncooperative. As much of the physical exam and workup that could be done was performed, which showed cranial nerve palsies in the 5th, 7th, and 12th cranial nerves, and pancytopenia, which is consistent with her chemotherapy. She had a CT and a CTA done, which were both negative, but on discussion with her oncologist, as well as clinical suspicion, she received a diffusion-weighted MRI, which showed restricted diffusion in the left centrum semio-valley of the frontal lobe. She was started on leucovorin rescue for suspected methotrexate-induced leukoencephalopathy, as well as IV acyclovir for HSV encephalitis. Neither of these therapies resolved her symptoms after 24 hours and were both discontinued. The patient was administered dextromethorphan-quinidine orally for a total of 7 days after the failure of the initial therapy. She ended up improving steadily, and follow-up MRI was consistent with a healing lesion. She was discharged with fluent speech, full function of the face and tongue with slight right-sided weakness, and a cooperative and appropriate mood. So major take-home points from this case are that ALL presents with a median age at diagnosis of 16 and is the most common cancer of children, while presentation in adults, such as this patient, is pretty uncommon. Methotrexate toxicity presents with a symptom profile of headache, hemiparesis, slurred speech, and CNS lesions, which were evidenced by this patient's physical exam. However, emotional lability, while an uncommon clinical indicator of toxicity, should certainly be considered in a patient displaying inappropriate emotions. Once toxicity is diagnosed, the gold standard treatment is leucovorin rescue following immediate cessation of intrathecal methotrexate. Dextromethorphan-quinidine, an NMDA antagonist, can be used to treat methotrexate-induced leukoencephalopathy when leucovorin is not sufficient. Lastly, in cases of seizure disorders such as this patient who has a remote history of unspecified seizure, post-ictal hypoperfusion or glutamate toxicity have been shown experimentally to damage and remodel the neural network, which predispose patients to behavior dysfunction and other brain abnormalities, which may have confounded our findings and confused our treatment, the directness of our treatment. Thank you very much.